As we move forward, I would like to introduce for the next important panel an esteemed medical leader, Dr. Beatrice Koch-Grozitsky. She's the Chief of Geriatric Services at Memorial Sloan Kettering Cancer Center. She's doing a lot of research in the area of geriatric care for patients in the oncology space. And I would like just to put things in a little bit of a perspective. Given our own experience at the University of Rochester and other places with telemedicine, basically, I've been fortunate to working for quite some time with Dr. Dorsey's group in neurology, but also with Dr. Friedman, University of Texas, doing telemedicine care for migraine headaches, and with Dr. Rajiv Ramachandran, who is looking primarily at diabetic retinopathy. And in all those cases, we find amazing results for telemedicine. What we also find in the research, which is also so exciting, is it provides the use of telemedicine gives us tremendous public health benefits. One, it reduces the burden of travel on patient. When you are elderly, you have motion disability, every mile is very expensive. Second, it dramatically can increase physician productivity. When you drive 4 hours to see your physician, you will never go out of the office in 10 or 12 minutes. But if you just make a quick phone call or quick video call, you have few questions answered and you feel equally satisfied. So it makes the physician more productive because the patient knows if another question comes up, I don't have to drive 100 miles and spend a day with my son or my daughter to bring me back and forth. The third benefit is improved specialty coverage for underserved population, those who live in areas far away from the specialized hospitals, and we can trust less and less many of those rural, unspecialized hospitals. Finally, telemedicine dramatically increases competition amongst providers. I can be in New York State and serve patients in Shanghai. I can be in Rochester and serve patients in Boston. Somebody can in Boston serve patients in Buffalo. So there are more choices for patients, increasing competition, the marketplace works and produce magnificent results. So these are the issues we would like to discuss and how the technology helps us with the aging in place in this panel. As we start the panel, we'll ask each one of the participants to briefly mention their name and their affiliation. And I would like Dr. Beatrice Grozitsky, please take the panel in your able hand. Thank you very much.
You're welcome. So good morning, everybody, and my name is Beatrice Cork, and I work in Memorial Sloan Kettering. And we are going to have this panel today. Each one of the panelists is going to speak for a few minutes, 7 to 8 minutes, and we are going to go from one to the other, and then we are going to give everybody the opportunity to answer questions at the end of all the talks together. So if you have a question, please remember it, write it down, and remember who you want to ask it to, and then we'll have a very long, like at least 20 minutes of Q&A after we finish. So without further ado, I'm going to introduce Dr. Lawrence Hoffman. And Dr. Lawrence Hoffman is a professor in Stanford School of Medicine. He's the chief of interventional radiology. He's the medical director of the cath lab and co-founder of Grand Rounds. And he is very interested in minimally invasive treatment of blood clots and DVTs in cancer. So
We're going to go to the podium.
I will.
Thank you. Do we have the slide advancer?
Oh, here's this. Am I in the way of your slides?
No, you're great.
Okay.
But I'll be talking to you the whole talk. So hi, my name's Rusty Hoffman. I'm professor in chief of interventional radiology at Stanford. I spend about half of my time taking care of patients, the other half of my time doing research, writing grants, doing administrative work, teaching, and also working in startup community. I'd like to thank Avi and Ray for the invitation to come out here and speak. So I'm going to talk a little bit about a company I started 3.5 years ago called Grand Rounds. We're about 150 people. We've raised over $50 million. We take care of people on 6 continents. And so this is kind of stuff we've done over the past 3.5 years. So I know we're talking about aging, but we're going to talk about a little boy named Grady first. He's the kid on the top. I have permission to use his likeness and his brother's likeness. So Grady, when he was 9, developed some problem with his liver. Normal, healthy kid, played baseball, football, basketball. He went into liver failure, was admitted to Stanford. Multiple doctors actually figured out a new way to take care of him, gave him IVIG and steroids, saved his liver. For the doctors in the room, his bilirubin was 16, his enzymes were 5,000, 6,000, almost lost his liver. 2 months later, unfortunately, the process continued and he developed aplastic anemia. For those of you in the room that don't know what aplastic anemia, when I went to medical school, fatality rate of 80%. That's where you no longer make red blood cells, white blood cells, or platelets. The treatment of choice, actually, for aplastic anemia is a bone marrow transplant from a sibling. So the doctors at Stanford typed the family, including the parents, met with the family, and they gave some interesting news. They said, well, Grady's brothers don't match him, but there's a parental match. The family was overjoyed, but the doctors there said, the problem is we don't have much experience with parental match. It's incredibly rare. We actually think maybe a better thing is to use an immunosuppressive drug called ATG, which is a kind of a nasty drug. So, okay, so they said, well, how do we make a decision? Like, we're really not sure. Well, the family from Silicon Valley was able to garner the resources to actually contact the first author of the paper that described ATG, talk to them, and he said, actually, with Grady and his counts are so low, it's probably a 50% chance that he could live, best case scenario. Family was not very happy with that, but the doctor said, you should talk to a gentleman named Dr. Jakob Dieg at the Hutch in Seattle, where bone marrow transplantation was invented. He has the most experience with aplastic anemia and parental donors. The family was able to get in contact with him, showed him Grady's counts and the family's, and he said, I think you should go with the parental match. 5% that he will die, 15% chance that he will have some horrific complication that will impair his life, forever. But he said, in order to make the doctors at Stanford feel better, I'm going to send you, to the parents, a paper that actually explains the 20-year experience at the Hutch. It's not published and will not be published for about another 18 months. So the family took the paper back to Stanford and they decided to do the transplant with Grady's dad's cells. So that's Grady's dad. That's me with a hat and sunglasses. So I went through every parent's nightmare, almost losing my son 3 years ago, and now he is a healthy, normal kid. Thank God that he was born to a professor at Stanford that was able to work his network to get the care that his son needed. And actually, the whole liver story is actually a paper now in pediatric transplantation that changed the way that type of disease is actually managed, and that's another story. But so it really got me to thinking about the care. I've seen it as an expert physician, as an interventional radiologist. I have people that fly from all over the world for me to do a special type of procedure to open their veins. And, it really got me thinking that we're now in this world of an intersection between aging and healthcare and medicine that I believe is a perfect storm. As we know, Americans are getting older. The older you get, the more thing that breaks on you, right? And you also can't actually tolerate, smaller insults. If you break your leg when you're 30, a few weeks later, you're back to work. If that happens when you're 80, it could be a fatal event. Medicine is more complex. I saw this firsthand with the 8 specialists that took care of my son. Deadly diseases like aplastic anemia is now becoming a chronic illness. Thank goodness that Grady is healthy. More technology with imaging, genomics, devices, and drugs has now required that more doctors are subspecialized in order to take care and render the care. And this has really developed an incredibly fragmented system, and almost all patients are left helpless. So I believe in the United States there's 2 tiers of health care, and it's not rich people and poor people like most people think, because I've taken care of billionaires that have gotten really crappy care. It's really what I believe are medical insiders. Medical insiders are doctors, nurses, CEOs of hospitals, executives in pharmaceuticals that know how to navigate the healthcare system in order to get the right care like I was able to get for Grady. And my goal was to be able to scale what I do on a daily basis for everyone that knows me on this planet. When they get sick, even if they live in Georgia, all the doctors in the rooms or executives know that when their loved one or someone else gets ill, all the hoops they go through to help that person get connected into the healthcare system. And the way we do it at Grand Rounds is we take world-leading medicine, the doctors at MGH, Duke, Hospital for Special Surgery, Boston Children's, UCSF, LA Children's, all across the country, and we give them, as well as patients, a profound data and design platform that's really born out of Silicon Valley. It's the same type of experience you have when you use Facebook or Twitter or Google, to really provide care for 1.8 million covered lives currently. We have about 80 national employers. We take care of Fortune 50 retailers, to including the Alaskan ice road truckers, get care through Grand Rounds. So how do we do it? We do it in a couple of ways. First and foremost is the opinions, where a patient gets sick in Topeka, Kansas with pancreatic cancer. They type in where they've been seen. We go get all their records. We get all their imaging. We index it. We organize it. We load it in the cloud, and we will have the chief of surgery at Stanford or at MGH review that imaging and render opinion that goes back to the patient. We have some other stuff that actually I don't have time to go into, but if you look at what our impact is, 45% of patients understand their condition very well before Grand Rounds, and afterwards it's 90%. And this translates into a 66% change in diagnosis and treatment, and we save over $10,000 per patient that uses our system for the employer. So we're saving real money, because if you get it right and you get it right fast, you save a lot of wasted cost. So educated patients are happy patients, and we're able to deliver better and more cost-effective care. Thank you.
Thank you. That was great. Mr. Xiao? Hi, how are you? So we are going to introduce our second speaker, Mr. Xiao. That's the way you pronounce it?
Xiao. Yeah.
Xiao, very good. The president and CEO of Holiday Retirement, and that was founded in 1971 with the goal of creating independent living for seniors. And today there is more than 300 different communities throughout the United States.
Yeah, that's right. You know, in terms of aging in place, I sort of represent, you know, the other place where people are aging in place today, which is in a senior living community. Holiday Retirement is the second largest senior housing company in the United States. We also have a community out in Shanghai. I've heard that a few times, but we have a community out in Shanghai that we're helping to operate there as well. And in terms of independent living, we're the largest independent living provider in the United States. And for those of you who don't know, the continuum of care in senior living, you've got sort of senior apartments, independent living, assisted living, and then you go up to nursing homes. So we're on the the far more independent side of the senior living spectrum. Over 35,000 residents underneath our umbrella today. In regards to aging in place, I'll talk to you a little bit about some of the major challenges we're having in senior living. First off, if you take a look at what we in senior living call the senior tsunami, and the amount of seniors that are coming around the corner versus the amount of senior communities that we have, really, if you look at total number of units available in senior living, it accounts for less than 2% of the whole senior population. So there is a huge rush right now to ensure that, hey, for those who need senior living, there's actually a place for them. There's probably more capital looking at senior living than ever before right now. So that's challenge number one for us as industry. Challenge number two, here in America, Americans are living longer and they're saving less. And that is a huge challenge, not just for Americans themselves, but in our industry as well. Right? The average monthly rent for one of our communities is around $3,500. There are some senior housing communities here in New York, where people are paying up to $15,000 a month in rent. Right? So with the growing demand, but then with the shrinking sort of retirement funding, I think that's another huge issue for the senior housing industry. The third one is something that you've heard already about. Folks like Seth from Honors trying to address is the fact of the amount of people who are able to actually care for the growing number of seniors. Right? I mean, right now, a few years ago, it was sort of a pyramid. Lots of young folks, fewer old folks, and there was enough, folks to care for the seniors. That's going to be flipped upside down pretty soon. Right? So I think Honor's doing a great thing in terms of connecting caregivers to seniors. But my bigger question is, can I get enough caregivers to actually care for all the seniors coming around the corner? When home health companies are paying the same amount as a McDonald's worker, that's tough, right? To get enough caregivers to actually care for seniors. And with the growing amount of seniors out there, it becomes a bigger issue there. So that's sort of challenge number 3 for the senior living industry. Which then brings me to sort of like, why am I here today, right? Look, there's a lot of change that's happening in this room with the companies that are here today. And it's up to us in the senior living industry to sort of keep up with you all. Because at the end of the day, we all care for the same folks. From a technology standpoint, I got to tell you, the average age of a senior housing community in the United States right now is around 15 to 18 years old. They weren't built with the technology to actually care for, having the EMR systems and having all those things in place. We're trying to catch up to everyone right now. In terms of, finding the right, again, the amount of caregivers out there, that's a huge, dilemma for us too. And I think, for those of you in this room who are, looking at ways, how can we actually address that need? We are looking at, funding, actually getting people trained down in Central America, and then bringing them up into the United States, again because of the lack of human capital out there. The reason I'm here today is, hey, look, what you guys are all doing are important to our industry, and we're also looking to invest in what you're doing, because us investing in you is going to help us in the long run as well. Okay.
Great, thank you so much. Mr. Jesser. He's the general manager of Live Health Online. See a doctor 24/7 on your computer or tablet, face-to-face conversation anytime, right? Anywhere?
Anytime. Thank you. Good afternoon. So yes, let me briefly just describe what Live Health Online is. First of all, I work for a company called Anthem. Anthem Inc. is a health plan that does business across the country. Here in New York, it's known as Empire. And I head up a telehealth service that we created called Live Health Online. And what it is within 10 minutes on average or less, anyone in this room, can be face-to-face with a board-certified doctor in a HIPAA-compliant, secure, live, high-def video conversation, 24 hours a day, 7 days a week, 365 days a year. And that visit today, the retail cost of that visit is $49. And that's by using a smartphone, tablet, or a PC. It's live now in 44 states. We're offering it to Anthem and Empire health plan members as a covered benefit. So for them, it may be less than $49. It may be whatever their copay is. We're offering it to, right now, about 14 million of those folks. And over the next year or so, it'll be up over 20 million. So backing up, this has a lot to do with all these things we're talking about. When we saw the technology, it was created by 2 brothers who are physicians in Boston. They're actually from Israel, and the company's called American Well. They created this technology, and as a health plan, we saw it, and we said, you know what? This health plans don't typically cover telephone calls to the doctor and things like that, and it frustrates a lot of doctors. But part of that reason is no one knows what happened. Was it a 5-minute call? Was it a 30-minute call? Is there a medical record? We saw this technology. It really brings the patient and the physician face-to-face. There is a medical record that's created. The patient's clearly identified. They have a choice of physicians. So if you log in right now in New York, you'll see 5 or 6 doctors that are available. You can see where they went to medical school and decide who you want to see. You can see their picture and their profile, and also how other people rated them. Common, just like when you're using Amazon or anything else. So it's easy to use. And that was something that wasn't there, and it's addressing 3 things. Access to care. On a Friday night or Sunday morning, your doctor may not be available. And the urgent cares might be full. You may not want to leave home or leave work. So it addresses that. It addresses affordability because the price point's very affordable. And really, it's one of those things that you never would have associated with a health plan 5 years ago, which is a consumer experience that's really good, that you really like. So that's just a quick screenshot. I think I described for you what this slide talks about, which is what it is. The doctors in most states can prescribe and then send it to your local Walgreens or CVS, wherever you'd like. You choose that. It's part of your profile. You don't need to have health insurance to use it. The mobile app, it started out as a web-only service, and then about a year and a half ago came out with the mobile app, and that has really been, now half the visits are on mobile and growing. So I think, as most of you know, people are not necessarily keeping their home computers up and living on their smartphones and tablets. Most common question people ask is my doctor on it? Well, that would be almost impossible to have everyone's doctor on it. Your doctors are all busy. So think of it as an urgent care in a cloud. So it isn't your doctor. However, the second part of our model, besides rolling this out across the country as an urgent care, is working with physician practices and letting them use the tool to web-enable their practice and customize it and offer it. They can offer it only to their patients if they'd like, or if they want to do some hours on Live Health Online, the public store, they can do that too. But the use cases around with a physician using this for their practice go beyond after-hours care. This gets into things like the patient with mobility issues who needs to come in for chronic disease management, and instead they can say, you know what, we're going to check on you in 3 weeks, but we're going to set up a video visit. You don't need transportation to be arranged. You don't need to come in. Managing chronic disease patients, being available after hours, or we'd like you to see our diabetic educator for the diabetic, and you don't have to come in for that. We'll set up a video visit for that. And then one of the things that we're focused on right now is building a behavioral health component for 2016. And what we're finding, there's a lot of people who going into the shrink, lying on the couch is something they don't want. That's the stigma. And they're less likely to get needed behavioral health therapy. So therapy really applies to something like this. You don't need to put hands on the patient. And what we're finding is the primary care doctor's offices are the ones that have a big need for therapy. They'll have a patient who they know is in a depressed state. They would love to be able to get them seen by somebody, and there's a 3-week, 4-week wait. They're going to send this person back out into the street. They're going to end up in the emergency room or doing something that's not wise, and they would love to be able to say, we're going to send you down the hall. We have a computer set up in a quiet office, and there's a counselor available. That's the kind of thing that we can do with technology, and you all know what the technology is like now. That'll actually improve access to care, improve affordability, and really improve the quality. So we're working with physicians, and the physicians that we work with, there's obviously different reactions. Some of the ones that are just out of school say, when can I start? This should have been, I'm expecting to see patients this way. Then there's others that are a few years from retiring that are saying, over my dead body. But what we do is it's very flexible. They can get involved in several different ways. They can just moonlight and say, you know what, my Thursday afternoons are open. I'll go ahead and log in. I have a New York license, and I'll see patients in New York. Or they can set themselves up to log in and have their brand. So in California, we have UCLA doctors that are available. You'll see their UCLA on their white profile, their white jacket. And then the most integrated approach is to actually have us build a practice for that practice, so they can put their brand on it, their doctors, offer it to their patients. And you know what? If they all go to bed at 10 o'clock at night and they say they're done, they can then forward the practice to Live Health Online. This is a medical group in New York, Crystal Run, that is doing this. We set up a practice for them, and this is just a screenshot of their website. So they make this available to their patients. And it's integrated with the Apple Health app, which is just one, but there's such an arms race going on with glucometers and digital otoscopes and devices and apps for healthcare. How does one integrate with everybody? So the nice thing is, if you're using the Apple Health app and if you're storing your glucose readings or your other things that may be pertinent to your doctor, when you go to use Live Health Online, it'll offer you the opportunity to share, and you can, with a click of a button, share, and the doctor can have access to all that. It also, for patient continuity, it's important, we've been talking about this, until there's that great NHIN in the sky that connects everybody, you as the patient can forward your record after the visit to your doctor or to a family member through encrypted email, and you can decide, because right now under HIPAA it's yours. Those are the slides I have, and I'd be happy to take questions when there are some.
Thank you very much. Dr. Kaus, Director of the Institution of Data Science at the University of Rochester, Fellow of the American Association of the Advancement of the Science for the Science.
Thank you.
Go ahead.
So we heard from Seth this morning about the honor system, a disruptive approach to supporting human caregivers in the home. I'd like to talk a little bit about ideas that are coming out of research on devices for supporting independent, safe aging in place. I want to start by thinking about the differences between GPS and maps. So what are the advantages of a GPS system? You get just-in-time prompts. The system will adapt to the user's choices and errors. Overall, it reduces the cognitive load on the driver and thus enhances the driver's independence. There are many cities that I would drive with a GPS system. I would not have the courage to drive with just a paper map. Well, as we age, our mobility may be reduced, but certainly our personal schedules become ever more complicated. So we have medication schedules, we have exercise and therapy schedules, we have toileting schedules, we have diet schedules, okay? And all these schedules become a great source of anxiety and stress. And in addition, that well, they should become, it's not irrational for people to become anxious about them, because when you start to make mistakes in your medications, you start to make mistakes in your toileting schedule, next thing you know, you're ended up in a nursing home. So the vision that a number of researchers have been pursuing in recent years is a life GPS. So we'd like a system that can track the state of the user as well as the time of day. So not just an ordinary calendar with reminders. We want to adapt to the user's activities. So for example, it comes to 12:30. If the user has not yet prepared lunch, you might want to remind the user, you better eat, because if you don't eat, you're going to become run down, forgetful, could lead to other errors. For toileting, if you have not toileted within 4 hours, then remind the user to toilet. Again, so it's not at a fixed time of day. We want the system to help the user recover from errors. So if a user misses a medication, helps guide the user in a step-by-step process what to do. Do you just skip that medication? Do you double up the next one, or so on? Again, reducing the anxiety over that error. When we did some focus groups on people who really needed prompting and reminding aids, one issue that came up a lot was prospective reminders were important. So you have a doctor's appointment in the afternoon, and a person might spend the entire morning worrying about getting ready to get to that doctor's meeting on time. So you want the system to be able to say, don't worry, I will remind you in plenty of time to get ready to go to the doctor's. And finally, provide a memory of what actually happened, because as we all know, changes in daily activities are an important sign for all kinds of medical conditions, cognitive decline, problems with your medications, and so on. So how can we sense day-to-day activities in the home? Early attempts to use computer vision are a fail, and they'll continue to be a fail for quite a while. However, we now know that simple, cheap, wearable environmental sensors can do an incredibly accurate job of making a record of what a person is doing in their home. So one particular approach that's been pretty well developed uses RFID tags on objects, so little postage stamp tags without batteries. They last essentially forever. Stick them on hundreds of objects in the home. Whenever that object is moved, the system can sense that the object's being moved. And the sensor that senses these RFID tags, it might be a wearable. That's a picture of a wearable RFID tag sensor developed at Intel Research Seattle. Or there's other technologies where there's a little accelerometer in the sensor, and so you just have an RFID reader for the whole house. So way back now, over 10 years ago, in a study some of my students were involved with between Intel and the University of Washington on a system called SHARP, showed that this technology could do a very accurate job, better than 90% precision and recall, for a wide variety of daily activities, whereas prior work had concentrated on single point solutions, so like a whole system designed just for medication prompting or just for toilet prompting. So it seems like we have that sensing side pretty well solved. The other part is, well, what about now using that sensing into this flexible reminding and prompting device? Again, there have been a number of projects at Georgia Tech, at CMU, and other places. I mentioned work we had at the University of Rochester, a joint project with a small company called Attention Control System to create a cell phone-based context-aware prompting system that, again, used these kinds of simple environmental sensors and a flexible scheduling algorithm. So the question is, where is my life GPS? How come we don't have it now? Well, many academic prototypes were built, but there were actually few robust systems and rigorous studies. Okay? Because the systems were built just enough to get a few papers published, not enough to be deployed in a long-term, wide-scale study. There were some attempts to commercialize some of these ideas around 2005 to 2010 that flopped. Particularly, there was Intel Health and GE Quiet Care. So I think that kind of also sort of discouraged people about the feasibility. But I think things are really changing, particularly just within the last year. So the first is that these new toolkits for iPhone and Android enable rapid creation of scalable commercial quality systems. So here that Honor has 25 people, right? So now it's actually feasible for a small research group to put together a system and do the kind of rigorous study that's needed to show its efficacy. And I think the innovation, the commercialization is not going to necessarily come from the Intels and the GEs, but it's going to be coming from the startups. So when Yo is an app that it just sends a message that says Yo. That's the only thing it does. It's worth $10 million. So I think the money is there. And I think we're going to see, again, just like with Honor, a lot of more startups in this area. Thank you.
Here you go. So I'm going to take a couple seconds of my time that is very short to thank you Professor Seidman, for the invitation. I am really humbled by this audience, and I'm really thrilled to be able to give you a little snapshot of what we do and to talk about cancer in the older adult. I am a geriatrician. I'm the service chief of geriatrics and memorial sloan kettering. I do not work with telemedicine or with an informational technology, but I think I can give you multiple ideas of situations in which telemedicine can be used. So as we all know about what we call the silver tsunami, I think silver tsunami is a very kind of a big word to use, but there is a lot of individuals that is going to be old in the next few years, and it's estimated that 70 million people in this country will be over the age of 65 by the year 2030. And why is this important, particularly for me, is that cancer is a disease of the aging. So this is a quality of care publication that was done by the Institute of Medicine a couple of years ago, which shows that more than 50% of the older adults, actually more than 50% of cancer diagnosis is done in patients over the age of 65. And if you look at how many are the deaths for cancer, is actually more than 50% of the deaths by cancer are in the older adults. And one important thing that I heard also today is that the chronic diseases are increasing, so the complexity of the patients as we get older also increases. And cancer, as it gets much better cure, it turned out to be gone from an acute disease to a chronic disease. So people actually are living with their cancer for years. They get cure of their cancer, and they need to be followed by the cancer. And this constitutes a huge group of individuals that are called in, as a whole, the survivorship. And the numbers of survivors that are projected to be by 2022 are about 18 million people. So who is going to take care of them? Who is going to follow them? How are we going to do the follow-up between the oncologists and the primary care? So one important question that we face every day is what is aging, and what is to being old? And that is a very different definition depending on who you talk to, right? Everybody is here, whoever is 65 and over don't feel that they're old at age 65. So we have to figure it out if an 85 is an 85. So on one side we can have an 85-year-old that is really frail, older gentleman sitting in a wheelchair, looking through the window in a nursing home, multiple comorbidities, multiple medications. And at the same time, we have a very robust 85-year-old full of life that is enjoying and is able to keep going with their life. So if both of these gentlemen have cancer at one point in their lives when they are 85, how are we going to determine who is going to be able to tolerate treatment, cancer treatment, whatever it is? So we have the question of, will the patient tolerate and benefit from the treatment? And every patient needs individualized evaluation to inform any cancer treatment decisions. How do we do that? How do we differentiate between the frail, right, the one person that we know has poor treatment tolerance, versus the fit, the person that probably will have a similar tolerance as a younger counterpart, versus a huge group in the middle that we don't really know. They look fine, but they are not really. How are we going to determine if they belong to one group or the other, or they just have these vulnerabilities that will going to make him fail in the treatment that is long, is costly for the family, for the patient, for the society, for everybody? So one of the ways that we have as geriatricians to do this is through what we call comprehensive geriatric assessment. That is a way of like a wholesome evaluation of the patient using different interdisciplinary individuals that includes not only the physician, the nurses, the nutritionists, physical therapists, pharmacists, social workers, etc. That is a long process, usually kind of costly. Each person will take about a couple of hours. In Memorial Sloan Kettering in about 2003, 2002, they understood the need of this approach into the evaluation or pre-evaluation or care of their cancer patients, and they established what is called the 65+ clinical geriatric program that it highlights the complex needs of the older adults with cancer, trying to provide comprehensive interdisciplinary care and to bring a way to put everything together in terms of research and new ideas. And in 2009 was when the geriatric service, that is the medical piece, came into play, and that is what I developed since then. So one of our main issues is how are we going to be able to make it practical. So these long, complex, comprehensive geriatric assessments, so it's practical for the oncologists, so they're going to do it, and they're going to be able to guide their decisions because of or taking into consideration the different situations of the patient. So we're taking advantage of this unique and overlapping expertise between geriatricians and oncologists and putting it all together and trying to answer for me what it is the most important questions at this time, that where I think that lots of things that we've heard today come into place in how to optimize the care for the older adults. One of them is how to develop and disseminate innovative models of cancer care, trying to having a personalized, patient-centered, individualized evaluation so they can get the care that they need specifically for their life situation and their life expectancy. Number two, how to introduce geriatric principles into routine oncology practice, and how to put all this long, comprehensive geriatric assessment in something that it can be through telemedicine, through a specific way that the patient can interact before getting to the practice or during the waiting room service, so the oncologists can have all the information by the time they see the patient. And the third, that I think is one of the most important ones in terms of who is going to do what and taking care of all these millions of survivors that are coming up, is how to educate primary care physicians and how to educate geriatricians on oncology principles so they can be a shared care and a continuity of care between the two groups. So I'm just going to leave those three thoughts open for anybody that has multiple possibilities or ideas in how to use technology to answer them. Thank you very much. And I'm going to let you introduce yourself.
Thank you so much. So it's great to be here, and I have to say I'm utterly astonished that I'm actually going to be able to talk. I completely anticipated that 5 people with a 7-minute limit would totally blow their time and leave me in the dust. I'm a geriatrician, health services researcher. I also work with the Hopkins Business Development Office to help push Hopkins IP out into the world and let people like you access Hopkins IP and expertise. And I think we've been able to be quite helpful to folks thinking about the care of older adults. What I want to talk about in terms of aging in place today is something called hospital at home. And this is one use case. This is a gentleman named Walter. I don't know if any of you were fans of the HBO series The Wire. Anyone? Probably the best thing ever on television. Walter lived in the area around season 2, the ports. And he's a classic Southeast Baltimore guy, old, multiple chronic conditions, former Beth Steel worker, and he was cared for in our house calls practice, a home-based primary care practice. So Hopkins docs would go out and see him in his home, try and meet him where he needed to be seen because he could not come into the office-based practice. Walter would sometimes get hospitalized, and he was really no shrinking violet. He was a man of great opinions, and these were his opinions about his hospital stay. He said, I can't get my breathing treatments on time, so I end up on a ventilator. He said the food stinks. Actually, he was a bit more graphic about that, but I cleaned it up for you all. No one would talk to him. It was a pretty lonely experience. One time he got confused and he got tied down, so he developed acute delirium and was physically restrained, and he never forgot that. Most humiliating experience of his life, and I don't know if any of you have ever seen a loved one become delirious. It's very, very distressing, and probably also has long-term cognitive effects. And as his providers, he would go into our hospital. He would always come home with a completely new set of medicines, and even as his providers within the system, we wouldn't know what was going on. So one day, Walter got sick, and I'll never forget this. We're at his house. He clearly has pneumonia. We said, Walter, you've got to go to the hospital. It's really time. And he said, listen, I am so sick and tired of you geniuses from Hopkins. You're great doctors, but you run a really crappy hotel, and I'm not going to the hospital. So thinking about patients like Walter who would refuse to go to the hospital, and then the flip side, as a geriatrician, sometimes the hardest clinical decision I have to make is whether to put a sick patient in the hospital. I can take care of their acute illness, but will they come out worse for wear just by having been in the hospital? So for people like this, these two use cases, we developed the construct of a hospital at home So provide acute hospital-level care in the home as a substitute for going to the hospital. And here's the basic model, version 1, that we've been working on for quite a while. But imagine you have pneumonia, heart failure, COPD, obstructive pulmonary disease, and you're having a flare. You go to the emergency department. An emergency room doctor says, "Sir, ma'am, you need to be in the hospital." You meet certain clinical eligibility criteria, and you say, "Sure, I'd like to be taken care of at home." And most people will say that. You go home, often by ambulance, maybe not. You get home, and then nurses and physicians come to your home, and they take care of you. You get your oxygen and your intravenous medicines and your x-rays and your ultrasounds at home. You can't do everything at home, but you can do a lot. And if you can choose the right patients, which we've been able to do, you can actually take care of these people quite effectively. And then once the patient's done in a few days, they can be discharged, and then you can provide post-acute care in a transition phase. You're not meant to read the slide, but just to show you that there is an extremely robust evidence base for hospital at home. So if you look in the international literature, where in countries with single-payer models it actually makes sense to keep people out of the hospital, this has been well studied. So in over 60 randomized controlled trials, if you put them all together, what you get is a 21% reduction in mortality at 6 months. So dead or alive at 6 months, 21% better if you're taken care of at home in randomized controlled trials, 24% reduction in readmissions. So just to let you know, there are no drugs that do that. Antibiotics and pneumococcal sepsis does not achieve that result in mortality. So it's a very strong result. Over the last few years, we've been trying to push the model out into the real world, get out of the ivory tower. That's the Johns Hopkins Hospital original building. That's the dome where Osler wrote his famous textbook of medicine. But we've been disseminating the model into the VA system, which is a very nice substrate. Some success in Medicare managed care and Medicare Advantage. There's a CMMI Innovation Challenge grant to test the model in a fee-for-service environment. Up the road a piece at Mount Sinai that we're collaborating with, working with some large home health companies that think they can make a go at this, and then some public-private partnerships, some of which have been more successful than others. But our real goal is to really push this out into practice, and we will need business partners to do this. You really cannot do this from an academic base. Australia was very successful in getting hospital at home out into the market by reimbursing it at the same rate as acute hospital care. And in Melbourne, in Victoria State, they realized that they probably would have had to have built another 500-bed hospital, but for hospital at home. And if you think capitalization costs of a hospital bed at about $2 to $2.5 million, it's a lot of money saved. So you all have been very nice, and I'm about to run out of time. But if I had had an MI, if one of my coronary arteries was blocked here, Beatrice would run over, she would start thumping on my chest, she would get me off to the hospital. I could be back here in time for lunch with a new stent in place. But that's not how intensive care started, right? It was a doc, it was a nurse watching over a patient with a monitor. They started putting these things together. Technology grew up around the beds, subspecialties grew up around the technology, and then you get a system like that. But that took 50 or 60 years. Hopefully it won't take quite that long this time. Thanks.
Questions? Whenever you have a question, please tell us who is the question directed to. Go ahead.
A question for Mr. Gesser on the implications or the trending from the press, by the way. The trending.
They want you to use a microphone.
Hi, Dr. Nancy Gales, Association of Healthcare Journalists and Integrative Healthcare Policy Consortium. My question is about the trending for this telemedicine, teledoc situation by insurers to cover integrative healthcare practitioners. We have Section 5101 in the Affordable Care Act that names integrative healthcare practitioners others than MDs. And we have Section 2706, which actually is non-discrimination, that insurance do need to cover these people. How is that going?
So you're talking about nurse practitioners, extenders?
I'm talking about others than nurse practitioners. I'm talking about chiropractors, acupuncturists, licensed massage therapists, homeopaths, anyone who's a licensed or state-certified practitioner is named in the Affordable Care Act as one of the providers.
So the offering that I described, Live Health Online, on purpose was not called LiveMD or LiveDocs. It's the design is to be a telehealth solution for healthcare. We started out with physicians, board-certified physicians. One of the reasons in particular is there's already this hesitancy. Well, it's this online thing, you know. So the model that we began with was just urgent care and physicians. What I do is take the feedback from the market, and so large employers, the thing they want next is behavioral health.
What is it?
Behavioral health,
yeah.
Therapy. There's access to getting therapy issues that are not being addressed. Not to say that you couldn't do some other professions. I don't know how you would do acupuncture or chiropractic, though, via telehealth.
Well, you do chiropractic in the same way that you do neuromuscular skeletal movement disorders by diagnosing visually what's going on, the same way you would Parkinson's or any other neuromuscular situation. And homeopathy is also a whole system of medicine, like Ayurveda is, where you can, it's pretty much taking the case and prescribing. No across state lines. A lot of these professions are not particularly licensed in each state, but they do hold state or national certification. And there is a non-discrimination amendment in place that insurers do have to provide those.
Well, we do, let me put my health plan hat on.
Yeah.
We do provide those benefits and follow all the laws, so you are covered. There is not what we don't see as the access issue to getting to see a chiropractor or to getting to see those professions. And so covering it doesn't necessarily mean that we don't have neurology, we don't have dermatology. When you offer a telehealth solution, you offer something because it's in the market. As those things evolve, if there's a solution in the market that makes sense, then that would
So the trend is what consumer demand is?
Consumer and employer.
Employer goes first.
Yes.
Although they were cost effective and very have shown efficacy.
I believe they do as well.
Yeah.
Thank you.
Okay. Any other questions for the panelist? Is the home admission reimbursed as an admission in our country?
So that is a major stumbling block to hospital at home right now. So in current fee-for-service Medicare, there's no way to get reimbursed for hospital at home. So as we develop the hospital at home at Hopkins, which we actually do not provide that care right now, so we did all of the development work over many years, and actually with support from senior management. But when you go to the hospital president and you say, sir, ma'am, here's what I'd like you to do. I'd like you to take that person who's in your emergency department who would have been admitted to a bed for which you would have gotten a payment from Medicare, and instead you send them home. This is God's work. I promise you they will have a much better outcome, but there is no reimbursement model for that. And then they say, you know, Bruce, it's really a good thing you have tenure because you would be out of here faster than you know what. But, you know, within Medicare Advantage, in theory, economic incentives line up. Although even within Medicare Advantage plans, you still have to break through the barriers of how care is currently constructed, and often you're fitting a square peg in a round hole. In the VA, it's a nice system because every single VA medical center has a home-based primary care program, that house calls kind of program. That often serves as a lovely substrate on which to then build the added needed services for hospital at home. And so we've had, and because it's a globally budgeted system, when you actually prevent someone from going into the hospital, it actually does save them money. And it also helps them with some of their other strategic issues in terms of, you know, they have a lot of trouble with queuing up and all of that. Integrated delivery systems seem to be the sweet spot right now. So probably one of our best adoptions was at Presbyterian Health Systems out in Albuquerque, New Mexico. They own their hospitals, they own their providers, and they had a Medicare Advantage plan. So they developed hospital at home. They use it for their Medicare Advantage patients. They free up hospital beds for which patients from other payers can get into those beds and get those payments as well. The goal of the CMMI Innovation Challenge grant that we're doing at Sinai is to do the use case and fee for service and develop data to inform a 30-day bundled payment for hospital at home.
Yes.
Hi. First of all, thank all of you. It was terrific. I'm Deborah Cascaro. I'm a journalist with the Journal of Medical Practice Management. My question is to Mr. John Jesser. I'm very interested, as a journalist and a compliance officer, when I call your Anthem, let's say, I call your service, how is the patient reimbursed or the doctor reimbursed? Is it like the longer you're on, the more money? Is it like E&M coding, level 1, 2, and 3, or comprehensive? What happens once I've made the phone call, you've allocated this doctor, the doctor's there, okay, I can work from 6 to 9 o'clock. My questions are, how's the patient reimbursed? How's the doctor reimbursed? How is that information then transmitted to that patient's primary care physician? I just trying to understand it better. Thank you.
Sure. I think I follow you. So a couple of things happen. First thing, if you happen to have an Anthem or Empire Health Plan, the system will automatically in real time do an eligibility check to see if you have coverage for that type of visit, and if you do, what the copay or cost share would be. So it takes that on your credit card, and then it automatically will submit the claim to the health plan on behalf of that provider, and a CPT code's used. So for those that are familiar, and then in this case, there are a lot of different models. This is, again, not a call, it's a live video visit, and the CPT code is 99444, which is an online visit. That's submitted to the health plan. The health plan then pays their portion if it's a covered benefit, and the physician's reimbursed on the back end. It's all handled just like almost like a billing office for a doctor. But you do the billing. In the case, it can be done either way. Either we can do the billing for the doctor, or they can do it themselves. Very flexible. Mm-hmm.
So we want to thank the panelists for these terrific presentations, and I guess you'll be available for questions. Okay.
I would like also to thank the panelists for a lot of stimulating presentation, many creative ideas. As you can see, there's a lot of experimentation going on. Technology allows us to do things we could only have dreamt about just a few years ago.